This is the last video in the 7.0 series. In this video, we're going to look at ST segment depression and T-wave inversion that are associated with ischemia as well as other potential causes. Here in the upper panel, we can see a P-wave, a QRS complex, and then an ST segment and a T-wave. You can see that even though the ST segment is slightly upsloping, it eventually returns to baseline, and so this is essentially a normal, flat, horizontal ST segment. Here below you can see that if we were to put a piece of paper and cover up the upper portion, we would see 3 or 4 millimeters of ST segment depression that is horizontal. In order for this ST segment depression to be representative of myocardial ischemia, it needs to meet a couple of criteria. It should be 1 or more millimeters of ST segment depression in association with some kind of chest pain or anginal equivalent, or it could be with exertion in the form of an exercise stress test. ST segment depression is thought to be associated with ischemia when the form is horizontal like it is here or downsloping. That excludes upsloping ST segment, which we tend to see like this but in a more prominent form during exercise. Also, it should have some kind of anatomic distribution, meaning that it shows up in the inferior leads or the lateral leads in some kind of anatomic grouping that is analogous to ST segment elevation in STEMIs. And then also this should be a change from previous tracings. If a patient has an underlying condition that causes their ST segments to be depressed and they've been there for the last 10 years, then we cannot say that those ST segment depressions correlate with their current symptoms. Let's look at this 12-lead EKG. Here we can see in leads 2, 3, and AVF, we have 2.5 to 3 millimeters of ST segment depression here, and here, and that's horizontal ST segment depression. I don't see much in the way of ST segment abnormalities in 1 and AVL, nor do I see any in the anterior leads, but around here to V5 and V6, we do see some downsloping ST segment depression and then more horizontal here. I would say that in a patient with risk factors and signs and symptoms of coronary ischemia, that this EKG sure looks like infralateral ischemia. Now, ST segment depression, in addition to ischemia, can be associated with a number of conditions. Now, we've already actually talked about a number of these, and so we're now going to move on to T-wave inversion. Like ST depression, T-wave inversion can be an indicator of myocardial ischemia, but it also can be associated with a number of other conditions. Here's a mnemonic to help remind you of the potential things that could be associated with T-wave inversion. We will review just a couple of the most important ones here in addition to ischemia. In ischemic T-wave inversions, they too should match a pattern. Here we've got an inferior set of T-wave inversions in 2, 3, and AVF. Sometimes T-wave inversions occur as a result of evolving myocardial infarction. Here we can see that there was previously an anterior MI, and now you can see that the ST segments are trying to normalize, which results here in these inverted T-wave. Now this is a different condition altogether, and I want you to look at this EKG for a long time and memorize this condition and try not to ever forget it. This EKG shows what we call Wellens waves or Wellens syndrome. In this EKG, what is prominent here are these deeply inverted T-waves in the mid-anterior leads V2, V3, V4, V5. Now, there are slight variations of Wellens syndrome, but anytime you see these deep anterior T-waves, particularly in a patient with chest discomfort and risk factors, you should take that seriously, because if it is a Wellens syndrome, these people have a very high likelihood, some 80%, of having significant LAD disease. So if a patient presents with chest discomfort risk factors and then they have this EKG, that makes them much more high risk than a patient with a normal EKG. Continuing with the theme of potentially life-threatening condition versus harmless finding, we can have T-wave inversions that are completely harmless. Here is the persistent juvenile pattern. You can see in the left, a 2-year-old boy's EKG shows these kind of deep T-wave inversions, and that's normal for kids because of their body habitus and electrical axis as it changes and grows with age. On the right-hand side, you can see a woman probably also with a very trim body habitus that is demonstrating this persistent juvenile pattern. We would not expect to see this in a 65-year-old diabetic with chest discomfort. That would be concerning for significant ischemic T-wave inversions. This EKG also I would burn into your brain and try not to forget it. This is an encephalon hemorrhage or a brain bleed of whatever kind, whether it's a subarachnoid or intracerebral hemorrhage. Here we can see these deep T-wave inversions in association with a brain bleed. Now, we have just talked about how T-wave inversions can be in association with ischemic heart disease, and so on more than a couple of occasions, a patient shows up which is unresponsive to the emergency department. They do an EKG, see these inverted T-waves, and they begin treating the patient like they're having an acute coronary syndrome. Of course, is going to include antiplatelet therapy, which is going to cause the bleeding in the brain to be worse. Always consider a brain bleed if you have deep T-wave inversions, particularly in the setting of comatose, unresponsive, or headache. To round out our treatment of indicators of ischemia and infarction, let's review the evolution of a myocardial infarction as it shows up on an EKG. So if we start here in this upper left-hand corner, this is a person that is completely normal with normal coronary perfusion. Here is a patient with early coronary thrombosis, and the first thing that we're going to see is a widening and an increase in height of T waves, referred to sometimes as hyperacute T waves. Now, these occur actually within a few minutes of the onset of an acute coronary syndrome or a STEMI, and because they occur so early in the course, they frequently have already evolved into ST segment elevations by the time the patient gets to the emergency department, so we do not frequently see hyperacute T waves as a leading indicator of an acute coronary syndrome. Nevertheless, it's good to keep in mind in case one should. Next is going to be ST segment elevations, which we spent a fair amount of time talking about. If we see this and it's a STEMI, we know that we need rapid treatment so that we can abort that full thickness transmural infarction into a subendocardial infarction and thereby spare the patient's left ventricular function and reduce their risk of cardiac death. If, however, the patient does not undergo sufficient treatment, then it may evolve into a Q-wave infarction. Here we can see a Q wave. As a result of necrosis of the full thickness of the transmural MI, there is an alteration in the electrical axis because the dead portion of the heart does not have any voltage or conductivity. As a result of that, we will sometimes see the formation of Q waves, and that will sometimes be referred to as a Q wave MI. Now, you do not have to have Q waves in order to have a full thickness completed transmural infarction, but you may see these Q waves as an indicator. Consequently, if you have a patient showing up in your clinic and says, I've had some chest discomfort for the last couple of weeks, his baseline EKG shows old, deep inferior T waves, that could be a warning sign from an old heart attack. Let's have a look at this 12-lead EKG. We can see in leads 2, 3, and AVF, those T waves are starting to get pretty juicy in terms of amplitude and width. We can see a similar thing in V5 and V6. This is, of course, hyperacute T waves. These are not a common presenting finding in emergency department evaluations of chest pain because of how early in the course of the ACS that they display. In order for a Q wave to satisfy requirements to represent a potential old infarction, it needs to have at least one small box in width, which isn't much, and then at least 1/3 of the amplitude of the overall QRS complex. On the left, we can see in 2, 3, and AVF, there are small Q waves that are normal, probably septal Q waves or something of that sort, and are not deep enough to satisfy the criteria of pathologic Q waves. On the other hand, we have 2, 3, and AVF. We can see that these are well broader than the 0.04 square, and that they are sufficiently deep to represent at least half in this case, and certainly 1/3 here of the overall QRS amplitude. Here we can see pathologic Q waves quite deep in V1 through V5, which probably represent a significant old anterior MI. And just a reminder that Q waves, just like ST segment depressions and ST segment elevations, can show up in various regions according to coronary anatomy, whether it be a lateral set of Q waves, an anterior set of Q waves, or whatever. Next up is going to be 8.0 electrolytes and environment.